Hello. Now we want to talk about metformin, the most prescribed glucose-lowering drug for type 2 diabetes, and which has its 60th anniversary this year. And I'm here with Sally Marshall, editor-in-chief of Diabetologia, that is currently publishing a review series on it, and Cliff Bailey, one of the people who actually brought us metformin. Can you tell a little bit about the history of metformin?
Metformin's got a really interesting history, because if we go back in Europe into the 16, 17, 1800s, a plant called Gallagher officinalis, goat's rue or French lilac, was used to treat symptoms that we recognize as symptoms of diabetes. And this plant was shown to be rich in a substance called guanidine, and guanidine in the early 1900s was shown to actually lower glucose levels. And this led to research around the early 1920s in which people actually produced a number of variants of guanidine, including metformin, interestingly, but did not take this any further in development. It was felt at that time that although there were other variants of guanidine, insulin was going to be the answer. So the biguanides were forgotten. And then they were used when there was an attempt to find a way around malaria. So at the time, they were even shown to lower glucose levels, but not taken any further. And then metformin was actually used to treat the flu. And there was an observation in the Philippines that it lowered glucose levels. So we fast forward until 1957, when Jean Stern, working with Denise Duval in John Aron's laboratory in Paris, actually looked at the biguanides in detail, selected out metformin as probably the most efficacious with the least side effects, and in 1957 produced the publication for the use in the treatment of people with type 2 diabetes, and that's where we get our 60th anniversary from, and the rest of the story, as they say, is history.
Although it wasn't that successful in the very beginning, it became very successful later on, right? Did it change clinical practice?
Well, it has a very checkered history, certainly from 1957 on, because at that time the sulfonylureas had just emerged. There were other biguanides. Fenformin was considered to be far more powerful than metformin. Buformin was also considered to be more potent. And these two biguanides were used, fenformin particularly in the States. And metformin was just hanging on in there, as they say. And it became evident as time went on that fenformin was associated with lactic acidosis. And eventually, in the late 1970s, fenformin became withdrawn. Now, metformin's reputation was tarnished by this because it was a member of the same class. But in fact, the risk of lactic acidosis with metformin was much, much less. Maybe a tenth, maybe less than a tenth. And although this was appreciated, the drug was not particularly used for a long time. And during the 1980s and the early 1990s, information gradually emerged of its effectiveness, but it didn't gain a lot of clinical traction. And it was not until 1994, when the drug was approved by the FDA and introduced into the USA in 1995, and considered to be then a drug that should be looked at in detail, that it started to mushroom out. And from there on in, of course, it has grown from being the minority oral agent for glucose lowering to becoming the first in the line of pharmacotherapies for type 2 diabetes.
Yes, but it's not just an interesting history, it's also a lot more complex what it's used for, what its actions are. I mean, otherwise that would be a whole series on reviews. So what else is out there for metformin?
Oh, there's a lot out there, and I think our little series here shows that. Coming back to diabetes, first of all, I think it's really important for us to remember that at the time metformin was introduced, the choice was lifestyle measures or insulin, perhaps sulfonylureas. The drug therapy causes hypoglycemia, low blood glucose levels, and weight gain. We know that metformin is weight neutral, if not weight loss encouraging, and we know that the incidence of hypoglycemia in metformin is virtually nothing. So it does have huge advantages over the therapies that we had earlier on in the last century, I guess. It's fascinating now that after such a long history, after 20, 30 years of use worldwide now for diabetes, we're beginning to see metformin playing a role in other areas of disease. Cancer, the biology of aging, polycystic ovarian syndrome, all sorts of areas where, even though we don't fully understand how metformin works, it seems that the mechanisms that the drug may work through are also involved in cancer, in inflammation, and in aging. And we're beginning to see laboratory work investigating that, and indeed some human trials of metformin out with the diabetes sphere. So repurposing of a very old drug for completely new areas. And it may even be that some of the benefits that we see of using metformin in type 2 diabetes are partly related to its glucose lowering effects, but might also be due to these other effects that we're just beginning to uncover.
So metformin is also used in pregnancy. Can you talk a little about that?
Yes, you're absolutely right. It is, even though it is not approved, it's not an official indication for the use of metformin. But we have really good data now about its use in gestational diabetes, diabetes that develops during pregnancy and then goes away at the end of pregnancy, particularly from the Round study published a number of years ago now, showing that the addition of metformin to lifestyle measures in women with gestational diabetes significantly reduced the adverse outcomes both for the mother and for the baby. And even more importantly, women much prefer metformin rather than insulin, which is the only other therapy licensed for use in pregnancy. So I think reflecting on the vast amount of safety data we have with metformin, building on that data, metformin is widely used now in the management of gestational diabetes with good outcome data to support its use.
Yeah, it's really quite interesting that we still don't understand the mechanism behind it.
I think the diabetes world has to say a big thank you to the UK PDS, because the UK PDS presented its information to the world in 1998 at the EASD meeting in Barcelona, and it became evident that metformin was able to actually reduce cardiovascular events. This reduction was something that not only was, I think, unexpected, but was extremely welcomed. And it would appear to be largely independent of the glucose lowering effect. So Sally has listed out all those metabolic features of metformin, which seem to be particularly advantageous and were certainly very useful in the early days of avoiding hypos and avoiding weight gain. But the ability to actually reduce cardiovascular events became a new era for diabetes, and it's one that we are going through now with our cardiovascular outcome trials, phase 4 safety trials. And we can see how metformin then has not only mushroomed in its use, but as you have heard, during the course of that mushrooming, observations have been made which point us into potential future additional uses of this drug. And the repurposing of an old agent into whole new areas has meant that something that people thought might have already run its course by now has gained a new youth.
Yes.
And some of that's reflected in one of the articles in our series, Metformin in type 1 diabetes.
Yes.
And again, we've just had the exciting results from the removal trial, metformin use in type 1 diabetes, looking at surrogate cardiovascular outcomes, and a big session here yesterday on further data from that study. So although we're all comfortable with using metformin in type 2 diabetes, there is some research coming to suggest that maybe we should also be extending that use into type 1 diabetes as well, purely for the cardiovascular benefit.
I think that as we've developed the experience with the drug, we can also underline the safety profile. And I think this is very important because use of the drug started off very cautiously. And that caution has been enabling the drug to be used now much more widely with confidence within fairly restricted limits, such that the usage of it can now be expanded. And in the past, there was a very clear renal boundary of EGFR, or in those days just GFR, that we didn't go below. And now it's evident that we can, through experience, go lower, but I think it's still important that we don't abuse the safety profile of the drug, and we are well aware that renal monitoring is important, that when we go below an EGFR of 60, we should be cautious about the dose, that I think the cutoff at around 45 EGFR mil per minute is probably a sensible one for starting the drug, and stopping with dose reduction down to an EGFR of around about 30 is also a sensible move. And I think as long as we keep the safety elements in mind, we can continue to gain the benefit from the drug.
I would agree.
Yeah, so we can learn a lot from the turbulent history of the drug.
Yeah, the turbulent history is really quite amazing because even in the last 30 years, there has been a complete swing between it being the minority drug and now being the primary drug. And if we look at its mode of action, which is of course countering insulin resistance, we can see that it works in a different manner to each of the other classes of glucose-lowering drug we have, and therefore it offers the advantage that it can be combined with any of those, as we need to add in a second and sometimes a third agent as the disease progresses.
Will we ever understand metformin?
Oh, that's a good one. Go on, Sally. Will we ever understand metformin, the enigma?
If you'd asked me that 30 years ago, I would have said I understand metformin exactly. Now, with the new evidence about genetics, perhaps suggesting that we can pick out people who will benefit most from metformin and people who might not do so, with the work on the liver and on the gastrointestinal tract, I'm a little bit confused, I think it's fair to say. There is a lot of new data there. There is nothing yet that's really pulling it all together, and it would be nice if we got to that space. But it's exciting. That means there is much more work for everyone, from basic scientists to clinicians, to contribute to.
I think one of the nice virtues of metformin is that it does a lot of different things to a small extent, and then collectively those things give us the clinical benefits, whereas in the case of many agents we're looking at one target But with metformin, I think we're looking at multiple small targets. And also we have to remember that the exposure of tissues to metformin varies enormously around the body. So the intestine is exposed to extremely large amounts of metformin, and we have yet to find out what it does to the microbiome. But we know, of course, that it alters glucose metabolism in the intestine, and by the time we get to the liver, glucose has been converted to lactate, and lactate's gone back to glucose, so we've got a little circle going on there. And that metformin is then going around other parts of the body where those tissues are exposed to much lower concentrations of metformin, and so we are seeing different modes of action in different tissues. So I think exciting opportunities for this drug for the future.
You mentioned microbiome there, and we do have a little section on the microbiome in the series, so I would encourage you to read that. There is some data there just emerging.
Yeah, I really enjoyed reading this one, and I'm looking forward to the even thicker one in 5 years.
5 might be optimistic, 10 perhaps.
Okay, 5 to 10. Okay, thank you very much.